and that really we don't have much of the drug-to-drug interaction. This does not mean that because of this we need to go for a certain medication and avoiding the other, but it has to be taken into consideration. So, in view of the available data, to go for chemo after chemo, definitely in the metastatic castrate-resistant prostate cancer, it's valid. To go for chemo after ARTA, yes, it's also valid. To go for ARTA after chemo, yes, again, we can go for this approach. But what about ARTA after another ARTA? I think what we have seen that the outcome is not that good at all. So you have to say no. Don't forget that we have other genomic alterations encountered in the backstage of disease in a significant proportion of cases, like those employed in the DNA repair, in the retinoblastoma gene. Loss of the retinoblastoma tumor suppressor gene would add to the dramatic backstage of disease when pathway and PI3K are gaining much popularity and are under intense investigation for this issue. Again, being in the molecular era, and we heard a lot about the tumor profiling, and in prostate cancer, upon disease progression on current conventional therapy, to go for biopsy again if you don't have the original biopsy valid and in good state to be reanalyzed through the multi-gene panel of DNA sequencing. If positive, here you can identify what you have actually as alterations of the tumor suppressor genes, retinoblastoma genes, B53, B53, B10 alterations. Here, this is the preferred situation for chemotherapy, cabazitaxel, carboplatin, or to go for clinical trial if was there. If you have BRCA1/2 deleterious variant, and we have differential effect now as coming from the last ASCO GU, you can go for the PARP inhibitors and germline test. If non-BRCA deleterious variants, PARP inhibitors or immune checkpoint inhibitors would be the ideal options. If we have mismatch repair deficiency or high tumor burden, high tumor mutation burden, I think this is definitely the role of the immune checkpoint inhibitors, and I think this will be tackled in the upcoming presentation by my friend, Professor Mohammed Yassin. If we don't have such alteration, you have to go for immunohistochemistry. If you don't have the facility from the start, and you go for immunohistochemistry, if it's positive for mismatch repair deficiency, again, this is the place for the immune checkpoint inhibitors. If you identify the neuroendocrine tumor or the small cell pathology of the prostate cancer, this is the place for the platinum-based chemotherapy. If negative, trial or salvage therapy, or do what you want, because we don't have really guidelines for this. Again, don't forget that the advanced prostate cancer landscape, definitely we are having now improved castration quality. We are going for the way to intensify our earlier approach. We have some data about how to sequence agents. Definitely better control of the androgen-addicted cells. But what's behind that? What about the hidden remaining monsters, the biological pathways? You have to consider this. Here I am going to stop. Thank you very much for your attention.
Thank you, Professor Mohammed, for your elegant, comprehensive talk with biological background of cancer prostate and a lot of information. Thanks a lot. Yes.
بس Dr. Mohammed, thank you for your fantastic presentation, Dr. Mohammed. As usual, we have heard a lot of data from prostate cancer from you usually. You mentioned, Dr. Mohammed, that no ARTA after ARTA in the resistant phase. But
Yes.
what about your opinion? Yes.
We don't have really impressive results as have seen from the trials regarding the response rate, the PSA nadir, or the radiographic progression-free survival. Think if you have failure on ARTA, don't expect it to have much impressive result when you go. It will be extremely short-lived and not impressive at all, even for the symptoms of the patient, as the radiographic progression-free survival would be definitely compromised.
But we have now a lot of data for the efficacy of ARTA in the sensitive phase and even in the localized high-risk phase. For those patients receiving this drug in the sensitive phase and progress in the sensitive phase, what's the role of any of them in the resistant phase after that?
Definitely, this is a special situation. When I am talking about castrate resistant, this is an issue. And when I am talking about a patient with metastatic hormone-sensitive disease following a long time, well controlled on the abiraterone, for example, or the enzalutamide plus ADT, there will be a chance because this is another phase of the disease. I am talking about castrate-resistant prostate cancer in specific. When we start with ARTA, definitely, all subsequent treatment lines will be less and less impressive at the same time. Less duration of response and less impressive. So don't waste your time when you know that you have other options to be given longer survival and better disease control.
Okay. What I mean in my question, if I use certain ARTA in the sensitive, it's preferred to use the other one in the resistant phase in order to avoid the prostate resistance.
Ahmed, it depends on the duration. If we have a patient well controlled for more than 12 months while using ADT plus ARTA, this patient is not a poor prognostic group. You can go for ARTA again, or you have to consider the specific characteristics of the patient. If he has extensive body mets, for example, if he's having more visceral disease, I think this is beyond the capacity of the ARTA, although what we have from the trials previously, it was incidental findings. But I think when we have aggressive disease rapidly dividing, this could be the best chance for chemotherapy, if not used before.
Thanks.
Dr. Muhammad, may I ask a question, please? Your opinion, please, regarding continuous administration of ADT versus intermittent in castrated-resistant prostatic cancer.
Okay. We have to track the evolution of the malignant cells from the start. Always we are going sensitive cellular clones and resistant clones.
Yes.
So if I am going to start my effective castration early, it means that I am going to eradicate better the sensitive clones, but it will still there in a small number of cells. So if I am going to stop the ADT, for example, and going for other treatment lines, as the patient now in hormone refractory phase, this will allow re-evolution of the hormonal clones. So maybe I could think of stopping the ADT in the hormone sensitive phase, although data by Maha Hussein from the RTOG, definitely we have survival advantage. I do believe that in the metastatic disease, we don't have a lot of time to try or to play. Give your patient the best, unless medically contraindicated or causing your patient not to live in a good shape.
Yes.
In the castrate-resistant phase, no doubt, we should not think of stopping the treatment unless if we have exhausted all the treatment lines. I'm going to stop for a while to allow re-expansion of the sensitive cellular clones, and then upon reinitiation or reintroduction of the ADT and the hormonal management, I will achieve some response. Because as you know from the late days that to stop treatment is one of the treatment options for patients with castrate-resistant prostate cancer, but due to the availability of such a hell of number of agents, I think it's not there now.
Okay. Is there any special consideration on using cabo after docetaxel in visceral mat on progression less than 1 year to reduce the dose, to prolong the duration? Your recommendation, please.
When you go
Or
back,
to use GSF support, especially in era of COVID?
definitely extremely wonderful question. When you go back to my slide, the docetaxel is still having dual place. The metastatic hormone sensitive disease and in the castration-resistant phase, either if not included before in the therapeutic platform, or if we have long time between the onset of disease, of treatment, and the disease progression. Here, I can re-challenge again docetaxel under these specific considerations. For the use of the GSF, I think no one, and I need to hear the comment from Amit about this also, and all our friends who are using cabazitaxel. I think no one is using 25 milligrams per meter.
Yes, 16.
No, we start with 20.
Yes.
All using
16.
20 milligram per meter square.
20 or even less, some recommendations 16. Yes.
Yeah.
Yes.
every 2 weeks.
Yes.
DCSF is the cornerstone in the management with cabazitaxel, whether we are talking about COVID or not COVID.
Yes,
Yes.
yes, definitely.
Totally agree.
Outcome definitely, because it will make the patient adherent to the
Yes.
treatment.
Yes.
Yes, exactly.
Thank you so much, Professor Mohammed. Is there any other question?
Yeah, I want to comment.
Dr. Mohammed,
Actually, yes.
please.
I think the maximum reachable dose or acceptable dose we can give the patient is 20 with colon-stimulating factor support. It's very important because I saw a lot of patients actually dying from cabazitaxel, actually,
Yes.
from the pancytopenia and especially neutropenia. But recently, I have one patient. I reached to total dose of 40 milligram every 3 weeks, and he's doing very good, actually, with colon-stimulating factor, of course. But he's very good. But unfortunately, after about 6 cycles, he relapsed. So I don't know actually if there is some genetic variations that detect the toxicity or something like this, because I wonder, this patient is 70 years old and he is doing very good regarding the toxicity, not the disease itself. I reached 40 milligram and he's good. Regarding docetaxel, also we have the chance for giving patient 40 milligram every very, very tolerable, actually, and also the result is very good. If the patient is not in very good performance status, that allows us to go for every 3 weeks schedule. Yes, we can go for every 2 weeks schedule, even with docetaxel, 40 milligram. Thank you.
As I asked Amit for this because I really, let me tell you something, in my practice, although against guidelines, in my patients, I have good patients of the prostate cancer, I'm going usually for the weekly schedule of docetaxel rather than every 3 weeks. And really, I didn't find any of discrepancies between the survival outcome or the response rate, even for patients with metastatic prostate cancer. For cabazitaxel, since a very long time, I admire the 20 milligrams. I tried 15 milligrams every 2 weeks when we had data about this, but it was somewhat more toxic. It seems that we have some delayed recovery of the hematopoietic with cabazitaxel. So 3 weeks is a good option for this.
Okay.
One last question for the sake of time, Dr. Mohammed. How to deal with patient progressing radiologically without biochemical failure, or patient with neuroendocrine differentiation from the start?
With neuroendocrine differentiation, I go first for platinum-based plus etoposide, the gold standard for this. And if I have progression after this, usually it will be short-lived response. Usually I go for irinotecan-based because this is extrapolated from our lung experience with cell lung cancer. Anyway, Ahmed, I think patient who is rapidly progressing, whatever we are talking about, the treatment, this is a lost patient. And is not going to entertain much longer survival. And I think also this patient should be integrated within a multidisciplinary approach with our friends in the palliative care setting.
Yes.
Thank you, Dr. Mohammed, for your excellent
thank you. Okay, thank you. Now I have the pleasure to introduce my dear colleague, Professor Mohammed Yassin. Dr. Mohammed Yassin will tackle a very important topic related to immunotherapy and targeted therapy in advanced cancer prostate. Dr. Mohammed.
First of all, I would like to thank the EMOG group for inviting me for this elegant educational day as usual. This was expected. I would like to thank Professor Lubna for her nice introduction. I would like to thank all my colleagues who attended today. It is usually very hard to talk after Professor Mohammed Abdallah. So this will make my presentation very hard, because Professor Mohammed Abdallah has talked a lot about molecular biology, and he is a master in molecular biology. So if you are a master in molecular biology, you can do everything. So he's making it very hard for me for my presentation. Anyway, I will share my presentation. Okay. My talk today is immunotherapy and targeted agents for metastatic castrate-resistant prostate cancer. These are my disclosures. So, as we see here, these are the approved systemic therapies for metastatic castrate-resistant prostate cancer. As Professor Mohammed and my colleagues have explained before, we have the ARTA. In first line, we have enzalutamide according to the PREVAIL trial, abiraterone according to the Q 300 2 trial. We have in second line abiraterone according to Q 300-01 and ENZA according to the AFFIRM trial. We have also docetaxel, either before ARTA or after ARTA. We have cabazitaxel in second line, and we have cabazitaxel according to the CARD trial in third trial, in third line trial. We have also radium-223 in first or second line, and we have recently the approval of olaparib according to the PROfound trial. And the proper sequencing of olaparib still is unclear, but it is after ARTA. And for the approval of rucaparib, it was after hormonal agents and vaccines. And we have also trials with zoledronic acid versus placebo as regarding time to first skeletal events as a primary endpoint or secondary endpoints, and denosumab versus zoledronic acid. So, therapeutic decision-making in metastatic castrate-resistant prostate cancer. Heterogeneity is a hallmark of metastatic castrate-resistant prostate cancer. Metastatic castrate-resistant prostate cancer space increasingly impacted by the movement of primarily AR-directed therapy early in the treatment course. Because as we all know, enzalutamide and abiraterone and even docetaxel is now a standard of care for metastatic hormone-sensitive prostate cancer. And as we have seen, and as Professor Mohammed Abdallah has shown us, there is cross-resistance, and there is no sense of using ENZA after abiraterone or abiraterone after ENZA. And the old post-docetaxel space is now occupied by the post-abi-ENZA space. Significant need for new agents in the metastatic castrate-resistant prostate cancer settings. Several agents approved for metastatic castrate-resistant prostate cancer, but optimal sequence is still unclear. None of these metastatic castrate-resistant prostate cancer trials compared the new agents with the current real-world standard therapy. Most of the trials have not included patients with EDT plus docetaxel or plus a novel endocrine agent in the castration-sensitive settings. So I will start with DNA repair and prostate cancer. Germline DNA repair mutation, 12% in men with metastatic prostate cancer, 5% in men with localized cancer prostate, 3% general population. As regarding somatic DNA repair mutations, 10% in men with metastatic castrate-resistant prostate cancer. Homologous recombinant repair mutation testing. We have either sample, archival samples can be used, example prostate biopsy or radical prostatectomy, while blood-based testing, also known as plasma-based testing, identifies circulating DNA alteration, have become more widely available recently, and quality is becoming increasingly higher. Here, the profound study design in which the eligibility criteria was metastatic castrate-resistant prostate cancer with disease progression on prior novel hormonal agents, example abiraterone or enza, alteration in one or more of any qualifying gene with a direct or indirect role in homologous recombinant repair. Cohort A was with BRCA1, BRCA2, or ATM, and patients were randomized to olaparib 300 milligram twice daily versus physician choice, either API or ENZA, versus cohort P for the other 12 genes, olaparib 300 milligram twice daily versus physician choice of ENZA or abiraterone. Primary endpoint is radiological progression-free survival in cohort A. Key secondary endpoints, radiographic progression-free survival in cohort A plus B, confirmed radiographic objective response rate in cohort A, time to pain progression in cohort A, and overall survival in cohort A. As we see here, radiologic progression-free survival in cohort A for BRCA1 or BRCA2 or ATM, median was 7.4 months versus 3.5 for ENZA or ABI, with a hazard ratio of 0.34, which is highly significant. And as regarding overall survival, the updated overall survival in cohort A, olaparib was 19.1 months, and the control arm was 14.7 months with a hazard ratio of 0.69. And after adjustment for crossover, the hazard ratio was 0.42. And remember, patients in the control arm after progression were allowed to receive olaparib as a treatment. And overall survival in cohort B for olaparib, it was 14.1 months, and the control arm was 11.5, with non-significant hazard ratio of 0.96. 0.96, and cohort B with adjustment for crossover. Again, there is a slight improvement in the hazard ratio to be 0.83. What about the other PARP inhibitor, rucaparib, Triton-2? It was an open-label phase 2 study in which patients with metastatic castrate-resistant prostate cancer and deleterious somatic or germline alteration in the HRR gene progression on AR-directed treatment for prostate cancer and one prior line of taxane base, and no prior PARP inhibitors or methoxantrone or cyclophosphamide or platinum-based chemotherapy. Patients have received rucaparib 300 milligram twice daily until radiographic progression or discrimination of any other reason. It was around 50.8 months, and according to the IRR evaluable population, it was 43.5. We had around 6.2% of patients with complete response, and according to independent RR, it was 11.3. Partial response was 44.6. We had patients with stable disease, 38.5. Progressive disease, only 9.2. As we see here from this beautiful waterfall plot, the tumor response in BRCA1 and BRCA2 cohort in the Triton-2. And we had patients with confirmed radiographic response and patients ongoing on response for the BRCA1 and BRCA2 cohort. This was a proof of concept to do a phase 3 study, which is a Triton 3 study, which is still ongoing, rucaparib versus physician choice therapy in metastatic castrate-resistant prostate cancer with homologous recombinant repair gene alteration. Here again, patients with metastatic castrate-resistant prostate cancer, deleterious somatic or germline BRCA1 or 2 or ATM, who have progressed on AR-directed treatment for prostate cancer and no prior PARP inhibitors or chemotherapy for metastatic castrate-resistant prostate cancer. Patients randomized 2:1 to rucaparib 600 milligram twice daily versus physician choice, either chemotherapy, docetaxel plus prednisone 75, or abiraterone or enzalutamide. And crossover from chemo to rucaparib was optional following progressive disease. Primary endpoint was radiographic progression-free survival, and we are still waiting for the results of the Triton 3. So, PARP inhibitors in prostate cancer, early observation, active drugs, some with long-term activity, response rate 40 to 60%, primary resistance 60 to 40%, not one size fits all, BRCA2 benefits the most, ATM no significant benefit, safety is acceptable, hematological toxicity, maybe a model for biomarker-driven targeted therapy. Resurgence of response rate is as an approved criteria for our trials. Selecting patients for PARP inhibitors currently used for treatment of adults with metastatic CRPC. Which mutation DNA repair genes benefit from PARP inhibition? BRCA2, BRCA1 may be most sensitive, PALP2 somewhat sensitive, ATM may be insensitive, and we are waiting for the results or the post-hoc analysis of other markers. Olaparib, according to the profound cohort genes, homologous recombinant repair genes, including BRCA, rucaparib, Triton2, BRCA1, and BRCA2, post-docetaxel only, sequencing after AR targeted therapy, abiraterone, enzalutamide, olaparib is a choice. And after chemotherapy and AR targeted therapy, rucaparib for now. Monotherapy is the current indication. Now we have trials combining PARP inhibitors with AR androgen receptor inhibitor pathway. And here are the evidence from preclinical data. The AR and homologous recombination pathway are interconnected. AR signaling regulates DNA repair. PARP regulates AR function. Synthetic lethality, EDT, and PARP inhibition may result in synthetic lethality. Preclinical data suggests that PARP inhibition may be synergistic with AR signaling. And now we have many phase 3 trials exploring the combination of AR targeted agents plus PARP inhibitor. Here we have the PROPEL trial, first line. This is a first line trial in which patients have never received any treatment in the metastatic castrate-resistant prostate cancer, and patients are certified to receive olaparib plus abiraterone versus placebo and abiraterone. And remember here, in this trial, crossover from placebo to olaparib was not permitted because in the control arm, here the patients are receiving a standard of care in the metastatic castrate-resistant prostate cancer, which is abiraterone. And crossover was allowed in the other trials because the control arm has included a placebo, and it is not ethical to leave a patient after progression without giving a treatment. The primary endpoint is radiological progression-free survival. Key secondary endpoints overall survival. Other trials is the TALAPRO-2 trial, in which it is also a first-line trial, talazoparib plus enza, a metastatic castrate-resistant prostate study confirming the dose of talazoparib, and the part 2 randomized double-blind placebo-controlled study. Patients are randomized to talazoparib plus enza versus placebo plus enza. Other trial is the CASPER trial, co-inhibition of androgen signaling and PARP in previously untreated metastatic castrate-resistant prostate cancer, rucaparib plus enza versus enza. And another trial is the Magnitude trial, first-line niraparib plus abiraterone acetate and prednisone in metastatic castrate-resistant prostate cancer. And here we have a cohort with homologous recombinant repair, niraparib once daily plus abiraterone versus placebo plus abiraterone, versus the other cohort without homologous recombinant repair alteration, niraparib plus abiraterone versus placebo plus abiraterone. Another pathway to be targeted is the AKT and the AR pathway. And here, the Hypertension 150 trial efficacy and safety from the phase 3 study of ipatasertib, a pan-AKT inhibitor, plus abiraterone versus placebo plus abiraterone in metastatic castrate-resistant prostate cancer. And this was presented by Professor Johan de Bono in virtual ESMO 2020. As we see here, what is the rationale for dual pathway inhibition? AKT and AR, crosstalk between the PI3K, AKT, and androgen receptor pathways leads to reciprocal activation when one of these pathways is inhibited, providing an alternative mechanism for tumor growth and survival. Dual targeting of both pathways may increase anti-tumor activity. Ipatasertib is a potent, novel, selective ATP competitive inhibitor of all three isoforms of AKT. Hypertension 150 study, patients with asymptomatic or mildly symptomatic metastatic castrate-resistant prostate cancer, no prior treatment for metastatic castrate-resistant prostate cancer. So this is a first-line trial. Stratification factors: tumor PTEN loss by immunohistochemistry, prior docetaxel in hormone-sensitive prostate cancer setting, progression by PSA only, presence of liver or lung metastasis, and the region in which the trial has been conducted. Randomization 1-to-1, ipatasertib 400 milligram plus abiraterone versus placebo plus abiraterone. And the primary endpoint was radiographic progression-free survival. Secondary endpoints include overall survival, time to pain progression, time to initiation of chemotherapy, overall response rate. As we see here, as regarding radiographic progression-free survival in the PTEN loss by immunohistochemistry, the median radiographic progression-free survival for ipatasertib plus abiraterone was 18.5 months versus 16.5 months for placebo plus ipatasertib, with a hazard ratio of 0.77. While in the intention to treat population, the hazard ratio was not significant, it was 0.84, and the median radiologic progression-free survival was 19.2 for ipatasertib plus abiraterone versus 16.6 months for abiraterone and placebo. While here we see something different. If the patients were tested for PTEN loss by NGS, the hazard ratio was 0.65, and the median radiologic progression-free survival was 19.1 months versus 14.2. Highly significant. So one of the caveats of this trial is the discrepancy between the results of NGS and immunohistochemistry. And I think in future trials, we have to unify our testing methods in our trials to test the genetic alterations, because as we see here, there was a big difference defined PTEN loss and immunohistochemistry defined PTEN loss. As regarding overall survival, it was not significant. It was the hazard ratio for PTEN loss by immunohistochemistry was 0.91. Intention to treat was 0.93. As regarding confirmed overall response rate and duration of response, as we see here for PTEN loss by immunohistochemistry, placebo plus abi was 39% overall response rate. For ipatasertib plus abi was 61%. While in the intention to treat, placebo plus abi was 44%, and ipatasertib plus abiraterone in the intention to treat was 61%. As regarding grade 3 and 4 adverse events, more than 2% difference between treatment arms, and the characteristics for ipatasertib was the rash and the maculopapular rash, diarrhea, and hyperglycemia. So the conclusion, which was presented by Professor De Bono, in this primary endpoint analysis, ipatasertib plus abiraterone as first-line treatment for metastatic castrate-resistant prostate cancer in significantly superior radiologic progression-free survival and anti-tumor activity compared with placebo plus abi in patients with PTEN loss metastatic castrate-resistant prostate cancer. Improvement of radiologic progression-free survival in the intention to treat was not statistically significant. Ipatasertib was associated with improved time to PSA progression and PSA response, as well as higher overall response rate in patients with measurable disease at baseline. Overall survival and other secondary endpoints remain immature and require further follow-up. Increased toxicity was observed with the addition of ipatasertib to abiraterone in line with prior observation in clinical studies, with a high proportion having dose alteration. Drug discontinuation may be avoided by instituting prophylactic loperamide and antihistaminic for managing diarrhea and cutaneous adverse events. Combining AR and AKT blockade with iptasertib plus abiraterone improves clinical outcome over AR blockade alone for PTEN loss metastatic castrate-resistant prostate cancer, which is a poor prognosis subset. 23, which is approved in the first line and second line. Alpha particles induce double-strand DNA breaks in adjacent tumor cells, short penetration of alpha emitters, 2 to 10 cell diameters, highly localized tumor cell killing, and minimal damage to surrounding normal tissue. We have the Alsimca phase 3 study, confirmed symptomatic castrate-resistant prostate cancer, more than 2 bone metastases, no known visceral metastasis, post-docetaxel or unfit for docetaxel. Here, patients are randomized 2 to 1 to radium-223, 50 kilobecquerel per kg plus best standard of care versus placebo saline plus best standard of care. And the median overall survival for radium was 14.9 months versus median overall survival 11.3. What about immunotherapy approach? We have active immunotherapy, tumor-associated antigen, antigen-specific immunotherapy with Sibulacil T, which is only approved in the US, which is the unforgotten immunotherapy. We have trials with pox virus-based vectors and DNA-based vaccines. We have passive immunotherapy, which is the future, and we are waiting for the results of the PSMA trials. And we have the immune check inhibitors, anti-PD-1, anti-PD-L1, and anti-CTL4. So, as regarding Sibulacil T vaccine therapy with pulsed dendritic cells, which is only approved in the US, these 1-2 results published show safety and a clear dose-related biologic activity. And we have the IMPACT trial, in which patients asymptomatic or minimally symptomatic metastatic castration-resistant are certified 2 to 1 Sibulacil every 2 weeks for 3 doses versus placebo, and after progression treated at physician discretion. Primary endpoint was overall survival, secondary endpoint objective disease progression, and the results for Sibulacil median overall survival was 25.7 months according to the IMPACT trial. Here, this is a very important area of investigations, and approvals in metastatic castrate-resistant prostate cancer very early and very shortly, according to several trials. I will show you how. It is one type of theranostics, which means in which we use the agents in treating and for diagnosis. Here, PSMA is a type 2 transmembrane glycoprotein, highly overexpressed in prostate cancer and extremely high castrate-resistant metastatic disease express PSMA. So, a phase 2 trial is the lutetium PSMA 617 open label phase 2 data. And as we see here on the right side, the beautiful waterfall plot of best change from baseline. PSA more than 50% decline was shown in 57% of the patient, and around 97% of patients experienced a PSA decline, which led to the very important trial. And I think the approval of lutetium PSMA will be according to the VISION trial, which is PSMA targeted therapy for metastatic castrate-resistant prostate cancer. A German retrospective study showed a biochemical response rate of 45% for lutetium PSMA 617, which lead or is a proof of concept for the phase 3 VISION trial, in which patients with metastatic progressive PSMA positive castrate-resistant prostate cancer with one bone or more bone or soft tissue metastasis, 1 prior taxane, 1 line of abiraterone or enzalutamide are certified 2 to 1 to best supportive care or best standard of care plus lutetium versus best standard of care or best supportive care. And the primary endpoint is overall survival. Another trial, which is a therapy trial, in which patients after failure of ARTA and taxanes, according to the CROWD trial, you have the option of cabazitaxel. Here, we are showing in the therapy trial, is lutetium PSMA better or cabazitaxel? PSMA target lutetium 177 is a promising new direction in prostate cancer. Patients were evaluated with PSMA PET scan, and a very important issue is that we should have an SUV target metastasis more than the standard SUV. PSMA PET negative patients were eligible in the trial. 70% were PSMA positive. So clinical use of lutetium PSMA 617. Lutetium PSMA can be optimally sequenced with cabazitaxel. Lutetium PSMA is a new agent that holds clinical benefit in patients with advanced disease. In clinical practice, cabazitaxel can be safely given following lutetium PSMA therapy. In the advanced setting, consider both options for patients in order to maximize clinical benefit plus response. Another important issue which was presented in last ESMO is the BiTE therapy, bispecific T-cell engager immunotherapy. BiTE molecules engage a patient's own T cells to attack and eradicate cancer cells. T cell activation induces transient cytokine release and tumor killing. Trinatumab is the first and only bispecific immunotherapy approved in oncology worldwide. EMG 160 is a half-life extended PSMA CD3 BiTE immunotherapy for metastatic castrate-resistant prostate cancer. And this was presented in ESMO Virtual 2020. PSA reduction best response were those dependent and occurred in 68.6 evaluable patients, and PSA reduction to more than 50% occurred in 34.3 evaluable patients. Remember, those patients are heavily pre-treated patients in metastatic castrate-resistant prostate cancer. To have such results, as we have seen in lutetium PSMA and in BiTE therapy with EMG 160, means that in the future we will have new approvals in metastatic castrate-resistant prostate cancer. So, in immune checkpoint inhibitors, we all know CTLA inhibitors, Epi and Tremi, and PD-1 antibodies, Nivo and Pembro. As we see, FDA grants accelerated approval to Pembro for first tissue site agnostic indication for patients with MSI high results. A very important trial which was a proof of concept for the next upcoming trials is the Keynote 199. In this trial, we had 5 cohorts in which patients have received Pembro for 35 cycles or until progressive disease or toxicity. Cohort 1, measurable disease with PD-L1 positive. Cohort 2, measurable disease PD-L1 negative. Cohort 3, bone metastasis, no measurable disease, any PD-L1 status. While cohort 4 and 5, receiving ENZA, no prior chemotherapy, any PD-L1 status, measurable disease, and cohort 5, bone metastasis, no measurable disease. And what was very interesting here for cohort 1 and cohort 2, PD-L1 positive and PD-L1 negative, from this waterfall plot, here we had responses in our patients, but there was no difference for patients who are PD-L1 positive or PD-L1 negative. And in 193 patients from all 3 cohorts, 11% experienced a more than 50% PSA reduction from baseline. Here, overall survival by cohort. Cohort 1, PD-L1 positive, 9.5 months. Cohort 2, PD-L1 negative, 8 months. Cohort 3, it was not reached. As we see here, PD-1 and PD-L1 had no impact for treating patients with Pembro in patients with measurable disease and bone predominant disease. Acceptable safety profile observed. Investigators suggest additional biomarkers evaluation needed to identify patients who may benefit from Pembro. Evidence of anti-tumor activity with Pembro in patients with DNA repair gene defect. So, what about combinations? What about the prostate cancer microenvironment? This is very important. PARP inhibition can lead to the accumulation of cytosolic DNA fragments, leads to activation of the STING pathway, which leads to increased type 1 interference, induction of immune check inhibitors, checkpoints, immune response. So, DNA damage cell function, which also is a proof of concept for combining PARP inhibitors and Pembro or other immune check inhibitors in our trials. A very important trial which was presented in the last GU 2021, which had 4 cohorts. Cohort 1, cohort A, pembro plus olaparib, and cohort B, pembro plus docetaxel, cohort C, pembro plus enzalutamide, and cohort D, pembro plus abiraterone plus prednisone. And here we will talk first about cohort A. Combination of pembro plus olaparib generally was tolerated and showed promising anti-tumor activity against molecularly unselected patients with chemotherapy and novel hormonal agents, which means patients here we are treating patients with olaparib plus pembro after failure of API or enzo and chemotherapy, which means those patients are heavily pretreated, and in the past we had no treatment for such patients. As we see here, the confirmed PSA response was ranged from 5.7 to 10.6% confirmed PSA response. And as we see from the waterfall plot, PSA percentage change from baseline, a decrease over 50% for PSA was seen in 11% of the patients, and in the total population, it was 36.6. As regarding radiologic progression-free survival, it was 4.3. But if we look at the overall survival, it was an overall survival for patients who have received no months overall survival is something very striking, which denotes we have to do an phase 3 trials. Here, as we see, with increased enrollment and additional follow-up, pembro plus olaparib continued to show promising activity in a molecular unselected metastatic castrate-resistant prostate cancer patient previously treated with chemotherapy and novel hormonal agents. Safety and tolerability profile of pembro plus olaparib combination therapy was consistent. Promising radiologic progression-free survival and overall survival data support further evaluation of pembro plus olaparib in molecular unselected patients with metastatic castrate-resistant prostate cancer previously treated with docetaxel with less than 1 other chemotherapy and with 1 or 2 novel hormonal agents. Randomized phase 3 study of pembro plus olaparib is open to enrollment for molecularly unselected patients who were pre-treated with enza for metastatic castrate-resistant prostate cancer or abiraterone acetate for metastatic hormone-sensitive prostate cancer or metastatic castrate-resistant prostate cancer and experienced progression on docetaxel chemotherapy. This is the KEYLINK 010 trial. Another important arm is the cohort B, pembro plus docetaxel, 75 milligram every 3 weeks. And here we see a better PSA response rate. The combination of pembro and chemotherapy is very important. As we have learned before that chemotherapy can increase tumor infiltrating lymphocytes. So there is a rationale behind combining chemotherapy and immunotherapy, as we have seen from lung trials and many other trials. The confirmed PSA response have reached 32.7 months, 7%, and in non-measurable disease, and in measurable it was 23.5. PSA percentage change from baseline, as we see from this waterfall plot, decrease more than 50% was seen in 37.8 months, and the PSA decrease from baseline in the total population was around 70.9 months. Again, this is very striking. Radiologic progression-free survival was 8.3 months, and the overall survival has reached 20.4 months, which leads here the promising data from this study support further evaluation of docetaxel plus prednisone with or without pembro in patients with metastatic castrate-resistant prostate cancer previously treated with abiraterone acetate or enza, and a randomized phase 3 study of docetaxel plus prednisone with or without pembro is open to enrollment of patients with metastatic castrate-resistant prostate cancer who are chemotherapy naive and were previously treated with 1 but not more than 1 next-generation hormonal agents for metastatic hormone-sensitive prostate cancer. The Keynote 921 trial. Another trial is the Checkmate 9KD arm B, nivo plus docetaxel. This trial also had many cohorts. One of the cohorts is Nivo plus docetaxel, and then for less than 10 cycles, and then Nivo maintenance or up to 2 years or until progressive disease or unacceptable toxicity. And here we see for all patients a median radiologic progression-free survival of 9 months, no prior hormonal treatment, novel hormonal treatment, 12 months, prior novel hormonal treatment, 8.5 months. While as regarding median overall survival, for all patients, we have reached 18.2 months, while patients who didn't receive any Enza or Abiraterone before, the median overall survival was not reached, and prior new Enza or Abiraterone, 16.2 months. Very promising results. So this slide concludes all the ongoing important trials about combination. And I think the future, the answer is in the combination. As Professor Mohammed Abdullah has said before, the AR pathway is interconnected, and we have many targets. As we see here, we have trials of Abiraterone plus olaparib, the PROPEL study, Abiraterone and niraparib magnitude study, Enza plus rucaparib Casper study, and Enza plus talazoparib Talapro 2 study. As regarding immunotherapy, avelumab plus talazoparib, Javelin Parab medley, and the Quest sertolizumab plus niraparib, and the durvalumab plus olaparib, and we have the Pembro olaparib killing 010 trial, as I told you before. And for Nivo and rucaparib, we have the Checkmate 9KD, which is one of the arms. And for other agents, we have also combinations of radium-223 NCT trial, one trial with olaparib and one trial with niraparib. And we have the chemotherapy plus rucaparib, in which patients will receive docetaxel and carboplatin, and then rucaparib maintenance, which is the Platiparb trial. And we have trials with lutetium PSMA plus olaparib also, and sidralumab with olaparib. So a very important issue is a role for liquid biopsy. Yes, to capture the genomic landscape of prostate cancer, we want to capture the AR gain, AR mutation, homologous repair defects, mismatch repair defects, P53 loss and mutation, P10 and PI3K aberration. As Professor Mohammed has shown out, these defects or alterations are very important for local therapy and relapse, but the importance of liquid biopsy is very important in the metastatic castrate-resistant prostate cancer, as we see here from the many alterations which were seen in the metastatic castrate-resistant prostate cancer. So this, I will end with the latest NCCN guidelines for prostate cancer. And here it is very important for patients with metastatic castrate-resistant prostate cancer to rebiopsy, because more than 30 to 40% of the patients in metastatic castrate-resistant prostate cancer can have small cell or neuroendocrine prostate cancer differentiation, which is one of the important mechanisms of resistance. And the other subtype is the adenocarcinoma, which was our talk. And the small cell neuroendocrine prostate cancer, as we all know, the treatment options are cisplatin etoposide or carboplatin etoposide or docetaxel carboplatin, and for second line irinotecan, like as Professor Mohammed has said a while ago. And here the algorithm depends on what was the first line of treatment in metastatic castrate-resistant prostate cancer. If it was Enza or Abiraterone, and then you will give docetaxel and then other agents, or if the patient has received docetaxel and didn't receive novel hormonal agents, to be for second line, and reserve cabazitaxel for third line. And now we have the approval of olaparib and rucaparib for patients who have olaparib for patients who have received androgen receptor antagonists, and rucaparib for patients who have received taxanes and novel hormonal agents. So we have many options now. We have also Pembro for MSI high patients, and the issue here is how to proper sequence our treatment in the landscape of metastatic castrate-resistant prostate cancer. And I think the answer will be in combination therapy, because all of the trials into combination therapy, itacertinib plus Abiraterone was a first-line trial. The combinations of PARP inhibitors and AR targeted therapy are all first-line trials without crossover. So this trial, I think, will give us a clear, direct answer on how to sequence our treatment and what is the best treatment for metastatic castrate-resistant prostate cancer. And as we have seen, for example, from the keynote 365, the combination of olaparib plus pembro had, for patients who have received 2 lines before, had an improved overall survival, and the combination of docetaxel plus pembro, we have reached an overall survival of more than 20 months. So the future is in the combination treatment. So my take-home messages today is several survival prolonging options, but optimal sequence is still unclear. Situation became more complex with advent of therapies for metastatic castrate-sensitive prostate cancer. We have the approval of docetaxel and enzalutamide and abiraterone, and for sure, these agents are used early and no longer used in metastatic castrate-resistant prostate cancer. Most experts are using API or ENZA as first line for men with metastatic castrate-resistant prostate cancer, which are approved nowadays for metastatic castrate-sensitive prostate cancer. Don't rely on PSA alone for treatment decision in men with metastatic castrate-resistant prostate cancer. We need imaging. Majority of patients who are fit for chemotherapy should be offered docetaxel and also one of the novel endocrine agent at some stage of their disease. Third-line treatment in patients who have received docetaxel plus and also a novel endocrine agents, progressive disease within 1 year, and who are fit, cabazitaxel according to the CART trial. Best use of radium-223 is unclear. Only symptomatic patients without lymph node bulk or visceral metastasis. API after ENZA showed low activity. ENZA abiraterone modest activity in selected patients, but it is not rationale. It is no sense to use either ENZA after API or API after ENZA. We have now a treatment for a molecular target subgroup, olaparib and rucaparib, but optimal sequence is still unclear. And as we all know from the PROfound study, the control arm contained ENZA or abiraterone, which are no longer used in metastatic castrate-resistant prostate cancer if those agents have been used early in metastatic hormone-sensitive prostate cancer. Should we change the control arm in our studies? This is very important because most of the control in the recent metastatic castrate-resistant prostate cancer had included drugs which were used in the metastatic hormone-sensitive prostate cancer. Should we prevent crossover our trials? But unfortunately, this is non-ethical, and we should give our patients a standard of care treatment after progression in the control arm. Should we unify our testing methods in our trial? This is very important. After the discrepancy between the results of immunohistochemistry and NGS in the potential 150 trial, we need more predictive markers, beta loss for ipatasertib, tracking AR operation, like as Professor Mohammed has said, and retinoblastoma 1 and P53 and P10 could improve selection of patients for AR targeting. The importance of rebiopsy in metastatic castrate-resistant prostate cancer for neuroendocrine differentiation, MSI, homologous repair, recombinant repair, and P10 loss, and combination therapy on the horizon, and we are waiting for the results. Thank you for your attention, and sorry for being late. Thank you.
Okay, thank you, Mohammed. It is very informative talk. Would you please, Mohammed, in radium-223,
yes,
is there any precaution consideration for the skeletal mats to preserve the bone marrow, or whatever the number of bone disseminated?
The positive trials with radium-223 were for symptomatic or asymptomatic patients in first line and second line with low burden disease. Low burden, yes. So the benefit is better for low burden than heavy metastasis. Yes.
Is there any data about the recommended number of bone mets?
No, there was no.
Just by definition.
Yes, but by definition, and we have now many trials combining radium-223.
Yes.
One trial is the peace trial with ENZA, and another trial is with abiraterone, and with PARP inhibitors olaparib. And we think that combining radium 223 plus other agents will be a promise in the future. Yes.
Okay. Thank you so much, Mohammed. Now I have the pleasure to introduce my young brother, Dr. Mohammed Hafni, a new star coming from Ain Shams University. Dr. Mohammed will present the last presentation with a title, Radiotherapy Tricks and Challenges in Cancer Prostate. Dr. Mohammed.
Thank you so much, Dr. Lobna, for this very, very nice intro for me. I don't deserve this. I don't.
No, you deserve more.
It's my great honor to be part of the EMOG event, this tremendous event, with my dear professors and colleagues. Let me share my screen now. Yes. Okay. Today we will discuss some radiotherapy tricks and the challenges in prostate cancer. I hope I can go rapidly through my presentation. The outlines of this presentation will be unveiling the radiotherapy techniques and the challenges, focus the eye on the skepticism about the optimal target volume for radiation treatment in different risk groups, discussing the different doses and the fractionation schemes, highlighting the future direction in radiation treatment in prostate cancer. As we know, the prostate gland consists of peripheral zone, which is the site of nearly all cancers, and transitional zone, which is the site of benign prostatic hyperplasia, and the central zone and anterior fibromuscular stroma, and also the epithelium composed of basal epithelial cells and columnar secretory cells, which secretes PSA and plasma, and some rare neuroendocrine cells, which is responsible for neuroendocrine tumor or small cell tumor, and it is one of the mechanisms of resistance. The lymphatic drainage is very crucial in lymph node delineation for radiotherapy in prostate cancer. The prostate drains into obturator lymph node, internal iliac lymph nodes, external iliac lymph nodes, up to common iliac and presacral lymph nodes. So let's dive through a case discussion. We have male patient, 62 years old, medically free, presented with progressive hematuria, dysuria, and frequency. His pelvic abdominal ultrasound revealed a large heterogeneous prostate with total PSA 15 nanogram per deciliter, free PSA 0.9, and the ratio was 0.11. Actually, I want to highlight that the ratio here is a very important tool in initial screening, because if we have the ratio more than 0.25, it is most probably benign disease. And if it is below 0.25, it is most probably malignant disease. And if it is below 0.1, it is highly suspicious of malignant disease. The ultrasound guided core biopsy revealed positive 6 cores with Gleason score group 3, 4 blood 3, unfavorable group. MRI pelvis revealed enlarged prostate with peripheral zone lesion biral 3, and the metastatic workup was free. So, what is the preferred management plan? Is it external beam radiotherapy alone, or brachytherapy alone, radical prostatectomy, radiotherapy plus short-term ADT, radiotherapy plus long-term ADT, or observation? Actually, in this patient with unfavorable intermediate risk group, we have two valid options here: radical prostatectomy or radiotherapy plus short-term ADT. And of course, if we have very, very short survival, we can discuss the observation, but it is not very common here. So the focus of this presentation will be on the external beam radiotherapy. So what are the indications for external beam radiotherapy generally in localized prostate cancer? The indications include as a sole treatment for low-risk prostate cancer in combination with ADT, either short-term for intermediate risk group or long-term for high-risk group, as adjuvant treatment after radical prostatectomy in high-risk patients, as salvage therapy for biochemical failure after radical prostatectomy. So we have to position the patient in supine position with immobilization with foot knee support or alpha cardle. And we have to instruct the patient to have comfortably full bladder and empty rectum. Usually theoretically based, we can go for daily enema, but actually it is very difficult. And actually it is, I don't see any patient that can adhere to daily enema, so we can use normal laxative like carbon tablets or something like this. I strongly recommend taking a look on Estro guidelines for basal for target volume delineation, and also Rtrg contouring atlas for pelvic lymph nodes and Rtrg contouring atlas for organs at risk. So, what is the optimum CTV to be included in this patient with unfavorable intermediate risk group? Is it prostate only, prostate and proximal seminal vesicles, prostate and whole seminal vesicles, prostate, seminal vesicles, and lymph nodes, and pelvic lymph nodes? The dilemma, yes. Here, in this patient, I'll go for prostate and proximal seminal vesicles. So what are the indications to include the seminal vesicle and pelvic lymph node? We will discuss it later. I have some problems with the presentation, but okay, it works right now. So we have to take a CT slice every 3 to 5 millimeter, starting from L3, 4 to 1 centimeter below the ischium. And MRI fusion is very crucial to detect the prostatic apex and seminal vesicle involvement. What is the target volume? We can't define GTV actually, so we will define upfront CTV, which includes the prostate and any extracapsular extension. And regarding seminal vesicle and elective pelvic lymph node irradiation, we have some historical approach based on some retrospective data with Roche formula or Barton nomograms. And the indications for seminal vesicle irradiation to the high dose volume include positive biopsy, high risk patient, calculated risk more than 15%, or we can include seminal vesicle to the intermediate dose region till 54 to 56 in the intermediate risk group. And in all cases and on all risk group, we must include the proximal 1 centimeter of the seminal vesicle. I mean proximal to the prostate, not to us. Because it's the most common site of seminal vesicle involvement. So if we decide to irradiate the pelvic lymph node, and we will discuss when we will irradiate it, we should include common iliac, external, internal iliac, presacral, and obturator lymph nodes. And the BTV actually is not standard. It is institutional based, but we commonly go for 7 to 10 millimeter all around the prostate and trimming it posteriorly to 3 to 5 millimeter at the prostate rectal interface. And regarding the pelvic lymph node irradiation, here is the Rtrg contouring atlas. We start contouring the pelvic lymph nodes, the distal common iliac at the L5S1 interspace, and going downward, placing about 7 millimeter margin around the iliac vessels, and we start contouring the presacral lymph nodes here at the top of S1 till the top of S3, 10 millimeter anterior to the sacral bone. And going downward, we don't include here, if we see here well, we don't go after superior gluteal artery, and we don't include the inferior gluteal artery, because if we include the inferior gluteal artery specifically, we will irradiate more the rectum, and it is not part of our CTV. We continue downward around the external and internal iliac vessels, and we'll stop contouring the external iliac lymph nodes at the top of femoral head, and we stop contouring the obturator lymph node at the top of symphysis pubis, as this figure shows. Regarding contouring of the prostate itself, I recommend it's recommended to start delineating the prostate from the mid gland, where it is very obvious, and going upward and downward to include either the proximal part of the seminal vesicle or all the seminal vesicles, according to our indications. And the hard part here, the prostatic apex. So how we define the prostatic apex? It is very easy to define it on the MRI if we have MRI fusion, and we must have MRI fusion. If we don't, so we will go for a tricky sign here. If we have MRI fusion, it's very clear that the upper genitourinary diaphragm, which has hourglass shape, just like this, hourglass shape, we stop contouring the prostate 1 to 2 slices before the upper genitourinary diaphragm. But if we rely on the CT, if we see here that the levator ini muscle is almost diverted, and when we go downward, it became more or less converted, and here it became fully converted, making some slits. So it's called slit sign. It's very difficult to identify in the CT, but okay, try to imagine here that this is slit sign here make an hourglass appearance. It is the upper genitourinary diaphragm, and we should stop contouring the prostatic apex 1 to 2 slices before genitourinary diaphragm. So it is a hot point here. What about the rule of elective pelvic lymph node irradiation? We have systematic review here, both based on two large prospective randomized controlled trial, the Rtrg 9413 study and GTOG1 study. The Rtrg 9413 study revealed that there was some progression-free survival in small subset of patients with unfavorable, intermediate, and high-risk disease with BCA less than 30, while Gleason score is from 7 to 10, or BCA less than 30, while Gleason score less than 7. And the long-term data from the long-term results from this study, published in 2019 on Lancet, revealed that there was two arms most probably equivalent to each other. Whole pelvic irradiation plus neoadjuvant hormonal therapy is equivalent to prostate only plus adjuvant hormonal treatment, of course, with more GI and G toxicity in the whole pelvic group. And we concluded that there's some benefit, only some benefit to irradiate the pelvic lymph nodes in very small subset of patients. And the other study was GTOG1 study, which revealed no benefit, no progression-free survival difference between patients who received elective pelvic lymph node irradiation and patients received prostate only. And this effect was consistent in both groups, low-risk group and high-risk group. So we should deal with this issue, the elective pelvic lymph node irradiation, very cautiously, because it increases toxicity while with very, very limited benefit. Of course, we have to go for pelvic lymph node irradiation. It's not called elective here if we have positive disease. So what about fractionation? Should we go for 70 gray over 35 conventional fractionation, or 78 to 80 conventional fractionation, or 60 gray over 20 fraction, or 72 over 30, or SPRT 35 to 40 over 5 fractions? Actually, all those options are valid except the first one, because we have data on dose escalation from MD Anderson and also from RTOG and VROG. All those, and Memorial Sloan Kettering Cancer Center, all those trials concluded that the higher dose results in significant improvement in biochemical control compared to the lower dose, and most of the study comparing 78 to 80 versus 70 gray. And the benefit was in the form of biochemical control and progression-free survival. Actually, there is no overall survival benefit till now, but there was some improvement in metastatic free survival, and there was no significant increase in grade 2 and more GI and G toxicity. So what about hypofractionation? As mentioned previously, what is the rationale of hypofractionation? The rationale of hypofractionation here is that the alpha over beta ratio of prostate cancer is very low, ranging from 1 to 3 gray, while the alpha over beta ratio to rectum and bladder is higher, about 5 gray. So we can increase the dose per fraction to improve the therapeutic ratio, which is improving the tumor control while decreasing the normal tissue complications. So this guidelines is the ASCO and AUA guidelines for addressing the hypofractionation in prostate cancer, addressing both actually moderately hypofractionated schedule and ultra hypofractionated schedules. And here is the most important moderately hypofractionated schedule, we have a CHEP trial, which revealed that 60 gray over 20 fraction is equivalent to conventional fractionation in 5-year biochemical disease-free survival without increase in GI and G toxicity. And also we have MD Anderson protocol, 72 over 30 fraction, equivalent to conventional fractionation, and the Rtog protocol, 70 gray over 28, and Hybro protocol. The Hybro trial is very important because it recruited more than 70% of the patient with high-risk disease, which the other trial lacks this good point. Here in CHEP trial, we have only 12 patients with high-risk disease, and in Rtog, all patients had low-risk disease, but in Hybro study, we have 70 patients with high-risk disease, and the effect is still consistent. The hypofractionation is equivalent, and of course, in the current era, we must stick to hypofractionation schedules. So ultra hypofractionation, what is the meaning of ultra hypofractionation? It means SPRT and doses more than 500 CGY per fraction. And Christopher and his colleagues revealed that in low risk patients, doses ranging from 36 to 40 gray leads to 5-year biochemical disease-free survival, about 95%, which is acceptable and equivalent to almost equivalent to conventional fractionation. And also we have this study with Loblo and his colleagues comparing SPRT versus low dose rate versus external beam radiotherapy, and concluded that there was no difference between the 3 modalities. And this is very important study, Hypo Radiotherapy prostate cancer, which addressing the role of ultra hypofractionation in intermediate and high risk disease. And they concluded that ultra hypofractionated radiotherapy was not inferior, was mostly equivalent to conventional fractionated scheme for intermediate and high risk disease, but with higher dose more than the low risk disease, reaching 42.7 in 7 sessions, with each session 6.1 gray. At median follow-up of 5 years, we have failure-free survival reaching 84 in both groups, but still we need more and more long-term data about the overall survival and biochemical control and metastatic-free survival. So it is promising, but not standard till now. And also, there was no significant difference in grade 2 or more GI and G toxicity. And here is the conclusion of SPRT in low-risk disease and the ongoing trials of ultra hypofractionation in intermediate and high-risk disease. And here's hyporadiotherapy prostate cancer is the most important one because it recruits more than 1,200 patients. So what about adjuvant and salvage treatment? After radical prostatectomy, we have the initial AUA Astro guidelines, which was published in 2013 based on SWOG ERTC and the RC trials, which favoring adjuvant and salvage radiotherapy based on only biochemical control in high-risk patient with positive margin or extracapsular extension, seminal vesicle, detectable PSA, or rising PSA in case of salvage radiotherapy more than or equal to 0.2 nanogram per milli in 2 consecutive measures. And here is the Rtog atlases for postoperative contouring in case of positive margin and in case of positive seminal vesicles. These guidelines, the AUA Astro guidelines, was amended in May 2019. And the key amendment was the use of hormonal treatment with salvage radiotherapy when salvage radiotherapy is indicated. Based on 2 large trials, Rtog 9601 study, which used bicalutamide 150 milligram for 24 months, 2 years, or GTOG 16 study, which was more compliant. They used 6 months of LHRH agonist with salvage radiotherapy, and both revealed more biochemical control, progression-free survival, and marginal survival benefit in adjuvant and salvage treatment only here. And here is how to delineate the in postoperative setting. We contour the tumor bed and we include the posterior third of the bladder at the upper part of the tumor bed. And when we are going downward, we include more of the bladder, reaching 2/3 of the bladder. And we finished contouring at the vesico-urethral anastomosis. Here we see the some urine here and did the last cut here. So last but not least, what about the local irradiation in metastatic prostate cancer? We have the stopgap meta-analysis, which based on pooled analysis from Stampede and HORID trials. And generally, there was no overall survival benefit in all patients, and there was no improvement in progression-free survival. But we have improvement in overall survival and the progression-free survival in subset of patients with low burden disease. In Stampede trial, they used either 36 gray over 6 fractions SPRT over 6 weeks, or 55 over 20 fractions conventional fractionation. And in HORID study, they used 70 gray over 35 fractions, or 58 over 19 fractions. And what is the definitions of low and high burden disease? As mentioned previously by my professors, we have Stampede definition, which based on charted definition, high metastatic burden was defined as 4 or more bone metastases, at least one of it outside the vertebral body or pelvis, or we have visceral metastasis or both. All patients with unlimited number of metastases, provided they are confined to lymph nodes and axial skeleton, and low burden disease. And the HORID definition of low burden disease or low volume disease is fewer than 5 bone lesion and the Gleason score less than 9. So when we see here the forest plot of all the patients, we don't have overall survival benefit. Here is the line crossing the line of significance. And we don't have also progression-free survival. We only have biochemical control benefit and failure-free survival benefit for all patients. But when we go for subgroup analysis based on the burden of the disease and the number of metastases, 5, less than 5, or more than 5, we have overall survival benefit in patients with less than 5 bone metastases, and also we have progression-free survival benefit. And I'm so sorry for my long presentation, and thank you.
Thank you, Dr. Muhammad, for this great presentation. As usual, actually, I usually say that radiotherapy is the art of oncology, and we have a limited number in Egypt for expert in radiation oncology, and actually you are one of them. Thank you for your time and for your presentation. Also, I thank my all professors and the colleagues in the panel today. We have a great job today that we cover the prostate cancer, all topics needed by young and expert oncologists in Egypt and the Middle East. Usually in EMOG group, we insist to introduce continuous medical education, and we insist and hoping to making and organizing a further meeting in the near future after Ramadan, inshallah. We thank all the panel. We thank Professor Lubna Azz Al-Arab for your time and your effort and supporting us today. Also Professor Dr. Muhammad Abdullah, Professor Dr. Muhammad Farouk, Professor Dr. Muhammad Yassin, Professor Dr. Ahmad Gaballa, Dr. Muhammad Hifni. Thanks Janssen for supporting this meeting and inviting Professor expert of urological oncology, Ahmed Bah from England. Hoping to see you in the near future face to face, inshallah.
Thank you, Dr. Ahmed, for this nice, elegant meeting, as usual. Alhamdulillah, and happy Ramadan for all the people. Thanks, dearest Professor Lubna, for chairing this event. Really, it was an honor. And inshallah, we will continue our medical education after Ramadan, bi'Iznillah, hopefully with breast cancer, inshallah, symposium. Thank you all, and see you soon. Assalamu alaikum.
Thank you all.
Bye-bye.
Thank you. Bye-bye. Bye-bye.